Hello, welcome to the next installment of Raise Plow, the Bellic Law podcast. Today, we're very fortunate to be joined by Dr. Towe from Cleveland, Ohio, a thoracic surgeon who has treated a number of patients with mesothelioma. And I wanted to start just by asking you, doctor, to introduce yourself and give us a little bit about your education and training and professional career.
Great. Well, again, thanks for having me. And, this is a topic sort of near and dear to my heart. So I think it's an important thing to talk about. But I was born overseas and grew up in Connecticut. I did my surgical training I did med school at Cornell in New York City and my surgical training there as well. I did a research fellowship at Memorial Sloan Kettering Cancer Center. And then I did my cardiothoracic surgery training with Harvey Pass, one of the big mesothelioma experts of the world at NYU. I moved to Cleveland in 2014, and I've been working here in the Department of Surgery at University Hospitals for the last 10 years. And my specialty really is all of thoracic surgery, but mostly thoracic oncology.
Excellent. Well, we are very happy to have you. Dr. Pass is a good friend, and being based in New York City, a lot of our mesothelioma patients here are treated with him when he was still doing clinical work at NYU. And obviously, having trained with him and worked with him, you learned a lot about mesothelioma and its diagnosis and treatment. Let me ask you to give us some basic background information about what mesothelioma is and how it's diagnosed.
Well, I think mesothelioma is, unfortunately, the most important thing is it's just a terrible form of cancer. It is very aggressive and can really show up in a variety of ways. Some people will present with difficulty breathing or pain in their chest, and they'll sort of wind down a pathway of probably initially thinking it's a pneumonia or seasonal allergies. And eventually they'll get in front of a CAT scanner or something, and they'll be found to have something abnormal in their chest. As a surgeon, we often get involved when people have fluid buildup in their chest, and they receive some sort of drainage procedure to drain the fluid out, and they're found to have cancerous cells in that fluid. We would meet them and sort of talk to them about the diagnosis and get additional tests. And that could, usually includes CAT scans, but also things called PET scans, and working with patients to get biopsies and things like that. So it's usually sort of a winding process with lots of scans and ultimately a biopsy to determine the diagnosis.
And the procedures that you're mentioning, the drawing of the fluid, which is a thoracentesis, and then a biopsy. Could you explain a little bit about why the biopsy is really the gold standard for diagnosis versus the fluid from the thoracentesis?
One of the things that's really important about mesothelioma is it's rare. So it's not a run-of-the-mill cancer like breast cancer where, experts exist all over the place. So it takes real expertise to understand what's going on. And that even occurs at the level of like looking at the tissue to make the diagnosis. Like our hospital has a mesothelioma expert just for checking and double checking these diagnoses to make sure that we understand the exact type of mesothelioma and to be sure that the diagnosis is accurate. It's a real challenge to diagnose this condition and to really understand it. And that nuance that comes from looking at a piece of tissue under the microscope and really understanding what it means is very important. Cancer is not just one thing. It's a different disease based on the exact type of cell that's replicating or growing in the body and based on stage. So stage refers to the sort of spreadedness, and there are these different categories of spreadedness that define treatment, and determining the exact histologic diagnosis and the exact stage it is so critical for people being given the correct treatment.
In in terms of the diagnosis and the pathology material from the tissue that you're talking about, you have many of our clients who have been diagnosed with mesothelioma go to a hospital, say in upstate New York or in Northeast Pennsylvania. They'll have a biopsy done. It will be read by the pathologist at the local hospital, but they also will often send it to the Mayo Clinic or Sloan Kettering or the
Yep.
Air Force pathology lab for what's referred to as a second read. And I'm wondering if you, both in that context, but also in the context of a thoracic surgeon doing a biopsy and ultimately treating patients, could comment a little bit about why it's important for patients to get to a mesothelioma expert like yourself, even if they're tre- initially seen at a good local hospital.
Oh, there's so much to it. I think patients often feel that the centers of excellence that aren't, the hospitals that aren't right next door to them are inconvenient. And certainly healthcare is inconvenient. It's awkward to drive a long way to see a doctor, but I really do think the expertise has value. Um, if you have a rare condition like mesothelioma, you really want someone that understands the nuance and has a sufficient experience to make an informed decision about your care. If you just read the medical journals or the textbooks, you might have a broad sense of what's right, but it doesn't really affect the sort of granular day-to-day decisions that are so important. It would be like trying to um, get an education by reading an encyclopedia. There's a lot of information in there, but what's important is kind of hard to cull out. And what's difficult is, by definition, the encyclopedia is already old. It's not personal. It's not information that's valuable to you, and it's not up to date. So if you're going to a real expert, they have not only a personal experience, but a connection to the medical literature that keeps their information really fresh. And that means that the decisions they're making in your care are personalized, they're up to date. And those are the two things you really want when you're talking to a doctor.
And in some respects, it's also a numbers game because
Totally.
even a good local hospital, Erie, Pennsylvania, Binghamton, New York, is only going to see one, maybe two mesothelioma cases
A
a
year.
year.
A year,
Uh,
one or two a year, right? That's like, that is not the sort of, you don't have the feel for the disease. You don't really have the feel for what's changing about how patients are. In a career, someone might see 20 at a small hospital, and that's just not enough to develop that rigorous understanding and that sort of relationship, not just to the patients, but the relationship to the disease. You want someone who really has that relationship, that familiarity, and to leverage that towards taking care of you. I sort of think you should be somewhere where they see 10 or 20 cases a year, not one.
so let's talk a little bit about the treatment options for mesothelioma. You're a surgeon, um, so obviously surgery is part of your portfolio for treating mesothelioma patients. And obviously there are other oncology treatments like chemotherapy and increasingly immunotherapy. Um, can you just summarize a little bit the different treatment options, and then we can talk a little more about the surgeries and how you approach it?
Sure. Again, I think this comes back to this broad understanding that mesothelioma is, one, a terrible form of cancer, but also not just one thing. Within mesothelioma are different subtypes, different, uh, they have different behaviors, and each of those behaviors is sort of treated differently. Some studies in the past some people in the past have advocated for really aggressive surgeries. So when I was in training, some hospitals were doing a lot of extrapleural pneumonectomies, which were pretty radical procedures to resect the entire pleural envelope and the lung. And Roger Flores came out with some studies when he was at Memorial Sloan Kettering, talking about trying to do this sort of cytoreductive surgery, the pleurectomy decortication surgery, which is sort of scraping the cancer from the lung and removing the lining of the chest cavity where the mesothelioma is. And some of his studies showed that pleurectomy decortication treatment, when combined with other chemotherapy type drugs, was actually better. It was safer for patients. And so over the last 25 years, there's been this sort of shift in how we take care of patients, a shift in the goals. And it comes down to understanding, one, histologic subtypes. This is very important. Stage, the extent of tumor and whether it is surgically resectable. And that might have to do with whether the cancer is spread to lymph nodes. And then we also have to decide how to give different treatments to people based on how strong they are. It's different to treat, a high school football player who's basically invincible versus a 95-year-old who's in a wheelchair and has other medical problems. Increasingly, we're also sort of focusing on biomarkers and other targeted treatments that might be ways to tackle this. But broadly, we think about treatment as systemic therapy. These are drugs that are given to your body, usually with an injection. And those are sometimes called platinum chemotherapy drugs. And you'd sort of get those injections weekly, maybe. There are also drugs called checkpoint inhibitors. These are a form of immunotherapy, which is still a drug, but different than chemotherapy. And this can sort of help your immune system fight the cancer itself. Sometimes these are combined with chemotherapy. And then there are some targeted therapies or investigational studies that involve tumor vaccines or other specific genetic targets as ways to try to disrupt what makes the cancer grow. Surgery. Sorry, go ahead. Yeah.
I was going to say, you mentioned these subtypes of mesothelioma, the three
histologies. Yeah.
Them being epithelial mesothelioma, sarcomatoid mesothelioma, and then what's referred to as biphasic, which is a combination,
right,
for lack of a better word. How does this subtype impact your evaluation of the patient?
Well, the subtypes have different sort of behaviors. Epithelioid is sort of widely regarded as the gentler version of the three, I guess. It has the best prognosis. And, when I'm seeing someone, we're trying to understand where their disease is, both in terms of how aggressive it is at the level of the tumor tissue itself, but also the extent of the disease relative to stage. So we think the best outcomes for people are those people that have limited cancer, small localized-ish cancers of the epithelioid type. For people that have extensive disease, cancer that's spread to other parts of their bodies, like their livers or things like that, bones, then certainly even epithelioid is associated with a poor prognosis. The sarcomatoid type tends to be more aggressive, and often we consider not as amenable to surgery. And really understanding those types can help us also understand the different treatments.
Yeah. I think one of the interesting things that's going on now with treatment guidelines for mesothelioma is that with some of the immunotherapy agents and even chemotherapy, the subtype may greatly impact response to.
Well, right. I think if you think about meso as three different diseases, you're probably not thinking about it right. Every case of meso is different, and it really could come down to specific genetic markers in how exactly it's treated. So again, if you're cracking open your dusty textbook and it says there are 3 types of mesothelioma, epithelioid, sarcomatoid, and mixed or biphasic, then you're missing the nuance of how we're thinking about these relative to tumor markers and other genetic characteristics that might be clues as to the best strategy to treat people.
All right. About surgery, how do you evaluate the patient for consideration of a surgical procedure?
Let's say they have the biopsy, it's epithelioid type. Let's say they have the staging scans, and we believe their disease really is localized. We need to talk a little bit about whether patients have appropriate fitness for surgery. So we want to be sure that they're fit, they're robust, that they're strong enough to have the operation. The operations are typically performed through big cuts and can be painful and have long recoveries. So it's the understanding the disease status, understanding their extent of disease, but also understanding whether someone is strong enough for the operation. So that might involve talking to their primary doctors or a cardiologist to be sure their heart and lungs are strong enough for surgery. And then also understanding their goals of surgery. Are people looking for symptom control? Are people looking for, do people need additional tissue for testing that maybe they don't already have? Are they looking for cure? Are they looking for local control? So everyone sort of comes into the operation with maybe different goals. It is difficult to cure people of mesothelioma, right? It is very difficult. And so we really need, if we're going to offer someone a radical surgery, to be sure that we're not hurting them along the way. And we need to sort of be sure that they're strong enough to get these treatments and that they're sort of going to sort of follow through with all the treatment they'll need to get that best outcome. So it really is an important process of selection when we're choosing the people to get these aggressive treatments, because they need to be able to sort of fly when we do it.
So find that a number of surgeons were doing this extrapleural pneumonectomy, often referred to as an EPP, which, as you described, major surgery, removing the lung, the diaphragm, big procedure. And then there was a shift towards the pleurectomy, which preserves the lung and hopefully other organs and diaphragm, and is really focused on removing the lining of the lung and the visible tumor to the extent that it can be removed.
Yeah.
What is the latest data and information about the benefit and risks of these type of procedures?
To be totally transparent, there's lots of information about this stuff. The best trials, the randomized trials we have, where we have information about people who we don't know what treatment they're going to get at the beginning of the study, and they're assigned to a treatment in a random fashion, and we follow those people over time to see which treatment is better. Those randomized trials are very informative. There have been 2 trials now called the MARS trials that have compared treatment with surgery in combination with other treatments like chemotherapy to chemotherapy alone. And those trials have not shown a benefit to surgery, even in the sort of select groups that we thought were the best ones. So these MARS trials have really made people question whether surgery is right. Now, to me, when we think about these trials, it's really important to recognize that just because the trials don't show benefit to everyone, it doesn't mean that the trials don't have benefits to some people. We've always known that patient selection is critical here. And that's patient selection, again, at the level of stage. It's at the level of fitness for surgery. It's at the level of their histology, certainly. And really being sure that those patients are fit enough to get this very intensive treatment regimen, which is a lot of things being mixed together. the trials, the information that were coming from the surgical studies suggests that surgery is not universally better than chemotherapy alone. But my personal belief is that there are still these roles where surgery can have a big impact on someone, can help their disease and really offer them something that other treatments can't.
I always like to say to my clients who ask for my advice about medical treatment, if you get on a plane, you want a pilot because pilots fly planes. If you go to a surgeon, surgeons operate. That's what they do.
Yeah.
And in addition to uh, being a mesothelioma expert, I know from my clients who you've treated, your extreme ethical and approach and conscientious approach to evaluating patients. Could you just talk a little bit about how you balance your role as a surgeon versus information from studies like Mars in trying to do what's best for each individual patient that you're seeing?
Wow. I mean, this is a big question. I think that the thing that really drew me to surgery was that it wasn't just the cutting and sewing. I think the implication is often that surgeons are like carpenters or plumbers who are just connecting pipes together. But at some deeper level, we're actually having to leverage the decision of whether to operate or not. And it's a really difficult decision. Because unlike a medical doctor, they could try you on a drug, and if it doesn't work, switch drugs. We can't switch the decision to operate midway, right? We're committing to that. And I take that commitment incredibly seriously because I really believe in seeing my patients through. So I think it's really important to understand the nuance of a condition, to have a deep personal experience with it, and so that you can help patients understand that what's happening to them and what surgery can do for them. To me, surgery can do things and treat mechanical, physical problems that medicines just can't. So I really believe that there's a role for this where other treatments won't and can't do it. In mesothelioma specifically, you don't want a pilot that's just flown 2 airplanes before. You want a pilot that spent thousands of hours in the air. And that's why it's important to find someone who really has expertise. They are the ones who are most likely to really understand at the granular level what's best for each person. And, the National Comprehensive Cancer Network, the NCCN, and other societies, every single one of them stresses the importance of real multidisciplinary decision-making. And the concept there is that you don't just want one expert making a decision. You want a group of people who are coming together and trying to leverage all of their collective insight to do what's best for you. I think you're right that some surgeons think about like patients are like a nail and they're a hammer, and like, what are you going to do, right? They're coming here for a surgery. I'm going to do a surgery. I think that's really the antithesis of what surgery should be. It's really more about helping patients sort of match or meet the treatment that's right for them. In a lot of cases, the solution to people's problem, a hammer is not going to fix it either. And so we have to just be sort of mindful of that and sort of leverage that expertise for patient benefit.
So take us through the process. You have diagnosed a patient with mesothelioma. You evaluate them for surgery. You determine they are a candidate in their individual situation. Take us through the process and the surgery that you're doing.
Okay, sure. Yeah. So when we think about getting a patient ready for surgery, they'll have met with an oncologist, they'll met with a radiation doctor, they'll be discussed at a tumor board. So we'll have this plan to approach them. In terms of the surgical approach, people will be taken to the operating room. They'll be put to sleep. They're typically put to sleep with a special tube that allows all the air from the ventilator to go to the non-surgical side so that the surgical side can be selectively deflated. The surgery is typically done through a cut across the back, which kind of wraps under the shoulder blade. Oftentimes, we enter the chest by spreading the ribs apart or even taking one of the ribs out so that we have more room to operate in the chest. And the first task is really to take the pleura away. So the pleura is the lining of the chest wall. It is the place that the mesothelioma starts, where it is. And so we separate that from the surrounding tissues. And in a neat way, during the surgery, it can sort of separate from the ribs and the chest wall. And it almost unzips. It's almost like Velcro kind of, and it peels down off of the chest wall. And this is, it's pretty satisfying as a surgeon because you feel like you're really scooping out the cancer, so to speak. And you can do a sort of dramatic job of getting all of that out from around the chest. Once that's out and sort of cleared, then we evaluate the lung itself. And there's often deposits of mesothelioma on the lung. This is what's called the visceral pleura, or the lining of the lung itself. And then we peel that off of the lung so that we're capable of kind of separating that from the lung tissue. This is all done sort of meticulously with surgical instruments. And so we peel all that away and inspect every little nook and cranny to get as much out as we can. In some places, like the heart sac or the diaphragm, if the mesothelioma is going into that and we can't peel it off, we'll cut that away and then replace it with a piece of man-made material we call mesh. After the surgery, we numb people's ribs. We leave drainage tubes in their chest, and then we close the wounds up. People often go to an ICU or someplace called a step-down-like environment, and they spend sort of round numbers, 5 days, maybe a week in the hospital, and then go home and hopefully back to normal life in a couple weeks.
Do you ever use any intraoperative chemotherapy in your procedures?
In my practice, I haven't. I know they were very popular, Brigham, specifically in the Boston hospitals through the 90s and early 2000s. It has not been a part of my practice. It was not something that Pass was doing when he was training me. And I haven't been convinced of its benefit. Some people really do like the intrapleural thoracic chemotherapy, but it's not been something I've done.
Okay. So now take us through the situation where you make the evaluation and you have determined for that particular individual surgery would not be a good option. What path do the non-surgical patients follow?
Well, a couple things. One is, obviously, I'm not making these decisions about surgery or not surgery alone. There's a team of experts, oftentimes a chemotherapy doctor called an oncologist, a radiation doctor, and then patients are presented at a tumor board. So there's supportive services. There's a whole team of people taking care of someone. So even if I'm not operating, we're all part of the same care team and trying to help. Patients who don't get treated with surgery typically get treated with chemotherapy or systemic type therapies like I was talking about before, and the oncologist would be in charge of that. There are patients who don't get surgical pleurectomy who still need a surgeon, though. And there are some things that surgery can do for symptom relief to drain fluid out of their chest that's very important. So one thing is, because the lining of the chest can be irritated by the cancer, it can build up fluid, and that can affect people's ability to breathe. So there are procedures that surgeons perform to help manage that fluid. By managing the fluid, it makes it easier for the patients to tolerate the chemotherapy drugs. And so these things kind of feed off each other in terms of helping establish treatment.
Could you talk a little more about those types of things, a Pleurex catheter, a talc pleurodesis, and just explain a little bit more about the types of procedures that help control fluid and some of the symptoms of mesothelioma?
Yeah, a lot of people present with fluid. So they present with fluid in their chest. Their doctors say something like, "Oh, you've got an infection in there. We'll drain it out," or maybe you have heart failure. But then they test the fluid and they find that people had the mesothelioma cancer. It's oftentimes then that they'll come to see a surgeon and we'll talk about establishing the diagnosis with the tissue biopsy through a procedure called VATS. VATS is spelled VATS and stands for video assisted thoracoscopic surgery. And it's like a video camera operation, typically through a very small cut, to sort of look inside, survey the extent of cancer, and often try to manage the fluid buildup at the same time. For people who we don't think are going to be surgical candidates, we sometimes use a chemical called talc that kind of coats the lung and the chest cavity and kind of sticks the lung open so that the fluid doesn't build up anymore. In clinical trials, talc is very effective. It does require a longish hospital stay, and there were some reported sort of not allergies to it, but reactions to it, unfavorable reactions in the past. My practice is usually to place a Pleurex catheter, which I think is just as effective and maybe even more effective. Pleurex catheter is like a soft rubber tube that's surgically implanted in the chest and sort of dangles out of your body and connects to a bottle that can suck the fluid out. When you're not using the bottle, it gets taped against your body and it's very sort of discreet. But it can be really good for keeping the fluid out, and patients, I think, really can breathe better and get their treatments easier.
So one of the unique things about mesothelioma is that it's what's referred to as a signature injury, in the sense that the known cause of mesothelioma is exposure to asbestos.
Yeah.
You work right now in a area that had significant heavy industrial plants and factories, but you also trained in New York. Can you talk a little bit about um, the types of jobs or exposures to asbestos that some of your patients have had?
Yeah. It's wild, honestly, because when you make this diagnosis, you say to people, "Have you ever been exposed to asbestos?" And most of them say no. And you say, "Well, the classic is, a shipyard worker, someone who works in a mine." Or they say, "No, I didn't know any of that stuff." And when you start talking to them, you realize that so many of us are touched by asbestos in ways we don't even know. And a lot of them say, "Oh, you know what? I worked as a machinist in college for 2 summers, and they asked us to wear these masks, and we never wore them. It was hot as hell in there." And so many people are touched by this really incredibly dangerous chemical, asbestos. And so there are those classic people who work in sort of manufacturing or machining and are exposed to those asbestos materials through that. But there are also what are called para-occupational exposures. So those are like women who wash the clothes of the people who are doing that work. And I did have a female patient with that. And then there are people that have really, it seems like almost trivial exposure. They're not in an asbestos mine. They're working, for a summer job in college, I helped tear shingles off of roofs. Or there was this old high school and they wanted me to go in and, salvage the old whatever. And I had to go in with a hammer and bust all that stuff out. It's, even things like that can give enough exposure to cause this disease.
Yeah, it is. You mentioned two, I think, really important points for people listening to this to understand, and one of them is just the range of exposures. I mean, we've represented dentists who used asbestos tape in making castings, and folks that have worked in laboratories, and people who have used talc, and also your point about people's understanding of their own exposures. We've had clients who literally were insulators with asbestos pipe covering, and will answer the question if they've ever were exposed to asbestos in the negative until, their work history is taken in the right way. And I think, as a doctor who takes a social history, or an attorney like myself who's trying to represent a client, part of the challenge is figuring out how to ask the question uh,
Right.
to get
And,
the answer.
I think for people in their 60s and 70s, like what they did for a summer job in college seems like a totally different world, but it doesn't take a lifetime of exposure for asbestos to get to sort of hurt you. And that's what's also really important is it's not like you have to have worked in a shipyard with asbestos for 40 years, getting a little bit exposure every day. Even a small exposure, a relatively small exposure can still be significant. And like you said, taking that really careful history is critical.
So one final question that I wanted to ask you about, you know, I know from our patients who you've treated, the level of humanity that you bring to your work as a surgeon. And this is obviously a really difficult diagnosis to give to a patient. Explaining the treatment options is difficult. And even just managing um, what many of our clients will describe as their medical treatment becoming a full-time job for them with
Yeah.
appointments. And how do you um, try to approach your patients when you're giving them a diagnosis like this and talking to them about the prognosis and treatment and just their overall quality of life?
It's another hard question. To me, it really comes down to respect. I think you have to really respect the patients and respect where they're coming from. Everyone's kind of coming from a different place in terms of what information they're ready to hear, what their goals are, and you need to really listen for that so you know how to deliver what they need. Not every patient needs every research study quoted, or um, some patients aren't ready to even talk about surgery, but just respecting where they are and who they are is the start of it. I also believe in radical transparency. I think a lot of doctors say, you'll be fine, everything's fine, fine, fine. But in this condition, people aren't fine. Like you said, even the ones who get the treatments, it's like a full-time job. And so you really have to be forthright and in understanding that that's the reality of this condition. I think patients really want that transparency. They really want their providers to be truthful, not sort of giving them a false rose-colored, sunny view of things. And so I really believe in trying to be radically honest and transparent about what's really happening, what to expect, and ultimately what surgery can do. I've seen the full spectrum of surgery, elevating people and hurting people, and just sort of being open with that, I think allows a better conversation about what's best for people.
You've been listening to Dr. Christopher Towe from University Hospitals in Cleveland, Ohio, a mesothelioma expert in diagnosing mesothelioma and surgical treatment, and certainly would encourage anybody who's been diagnosed with mesothelioma in Ohio, Pennsylvania, upstate New York, who's within distance, to reach out to Dr. Towe. We want to thank you so much for joining us on our podcast, and appreciate your insights so much.